I'm one of the geriatricians and palliative medicine docs here. And I got asked to speak because I kind of got thrown into an outbreak at a facility where I am the advisory physician. So I'm just going to talk a little bit about what I've been experiencing. Next slide. So this is just a little bit of a look at the facility where I go. It's an assisted living facility, and it has a locked memory care unit where residents are able to kind of wander around. The goal is to make it feel like a home-like environment. So the residents have communal areas, and then they have their apartments around these kind of congregate areas, and each wing is labeled as a neighborhood. Next slide. So kind of around March 20th is when this facility really started to kick into high gear some of the more intensive screening protocols. They were working with the IDPH, considering that this was actually a dementia care facility. It made things a little bit more complicated, but they started limiting visitors, and their more intensive screening protocols began March 20th. Essential people were still allowed into the facility. So physicians, home health, hospice workers, caregivers, and actually for our dementia patients, IDPH included family members in that category. So it was still actually a pretty large amount of people that were coming in and out, but they were doing some of the other screening, like checking temperatures and asking questions at that point. So a little bit about our first case. She is a 99-year-old lady and has fairly advanced Alzheimer's dementia. She has a limited verbal capacity. She's dependent in all of her IADLs and ADLs, except she can feed herself still at this point, and she's able to ambulate a few steps. And she lives in one of these closed dementia units in the assisted living section. Next slide. So on March 30th, the on-call doc was called that she had a fever to 101, and the on-call doc immediately isolated her to her room that evening. The next morning, I saw her remotely via telemedicine, and she had developed a dry cough, and her temperature was 100.8, but otherwise she was completely asymptomatic and doing fine. That day, it was about a 6-hour-long process on the phone with IDPH trying to figure out what we should do and how we could get COVID, flu, and a respiratory pathogen panel, none of which any of the labs that come into the facility regularly to do testing were able to do. And we actually, thankfully, were able to track down. The facility randomly had one swab available left over from flu season that we were able to work with the IDPH and use. So we were able to get testing for all three of those things. The next day, she had a chest x-ray that showed a new left lower lobe infiltrate. And on April 3rd, her COVID testing returned positive. Next slide. So since that time, and these numbers change every single day, we have had 17 out of the 46 residents at this facility test positive, so about 37%. 10 staff members that I know of that may have changed by now, and there's 3 people under investigation. And of those positive residents, only 4 have been able to remain at the facility where we're treating them in place. So actually 13 residents have now been hospitalized, and 8 of those residents have spent some time in the intensive care unit. And actually, as of this morning, there have been 2 deaths at this facility, and 1 has been admitted to hospice care. So it is an ongoing process at the facility. It seems like the cases are starting to slow down, but we're still seeing them. And I imagine there are many other patients that are positive that have not met criteria for testing through the IDPH that we are not picking up yet. Next slide. So just a little bit, again, this is a small sample size, but just a little bit about some of the clinical presentations that I've been seeing in the facility, because I will say that the kind of classic respiratory presentation has been in the minority of what I have seen, which is how I actually ended up getting exposed to a few of these patients. But the first presentation has just kind of been patients who have had altered mental status. They're just not eating and drinking well. Labs may show a little bit of AKI, and they're just having some mild GI symptoms, maybe an episode or two of loose stools. But and this has kind of been the most common presentation that I've seen. No one has had fevers or respiratory symptoms in this group. They've gotten admitted to the hospital for, kind of some of the other symptoms that I've mentioned and tested positive at the hospital. The second presentation has been those patients that have had temps kind of between 100 to 102, who've had mild to moderate respiratory symptoms, maybe a little bit of GI involvement. And then these patients have slowly started to improve. The third presentation, which from the respiratory standpoint, this has been the most common presentation, where the patients will have fevers, they'll have these mild to moderate respiratory symptoms for several days, and then we're kind of seeing around day 7, they start to develop rapid hypoxic respiratory failure and get transferred to the hospital. There's still several patients at the facility whose temperatures are kind of between 99 to 99.9, and they have some constitutional or GI symptoms. These patients right now don't meet criteria for IDPH testing, so I haven't been able to test these patients, but I am suspicious that some of them likely are positive for COVID. Next slide. So, kind of thinking a little bit about what obviously this massive COVID outbreak has meant for me, and some things that we've seen and for our families is that it's been really interesting, especially as a palliative medicine doctor, and difficult because obviously the second that I decide to swab somebody for COVID, I'm trying to talk to them about advanced care planning and goals of care. And some people that have been steadfast in certain wishes are wavering. Some people who have never wanted to talk about this in the past are willing now. But it's been a very different type of conversation with family members where you have a real threat, and it's something that that they often, I think, have to make a decision about, and so it's been very different than many of the other conversations that I've had in the past around this. But my facility also has really tried to promote a lot of transparency about the outbreak in the facility. So the day that the first case was diagnosed, they notified all the family members and all the staff, which I think was great. And every day they send an update with the number of new cases that have been diagnosed and the situation for who's in the hospital and who's not. Some families have actually decided to take their loved ones home and care for them at home. These have often been really quick, kind of poorly executed removals of the residents from the facility. Just last week, I had a major medication error where a family took her mother out in the middle of the night on a Sunday and didn't get a lot of education about meds, and accidentally overdosed her mother on Lantus the next day. And thankfully, we had a telemedicine visit scheduled. And when we were reviewing the meds, I realized that she'd given her 100 units of Lantus instead of 20. We also actually had a paramedic who filed a complaint about the facility to the state, saying that I was transferring too many patients to the hospital. He was recommending that I transfer my hypoxic patients to a skilled nursing facility. So I actually had to go through and justify everyone that I had transferred to the hospital and why. Next slide. We've also had a lot of staffing challenges since this has happened. So the day that the first case was diagnosed, a lot of the staff quit out of fear for having to take care of these patients. The day that our first case was diagnosed, the facility had 30 gowns and 30 face masks available in the facility. Thankfully, the IDPH has stepped in and has helped rectify that a little bit. But the first few days there, especially when we were diagnosing a lot of cases, were very stressful for the staff and very harried. A lot of the staff has been out ill. Of course, as you can see, many of the staff members have come back positive for COVID as well. Many of these patients, on top of their living situation, have had caregivers. That's been a major issue for us in the facility, is trying to find private caregivers for these patients. The private caregivers are often kind of grounding they're kind of a grounding stone for our patients with dementia, and many of them either haven't been able to come or have refused to come, obviously, and take care of patients who have COVID. And also the level of care needs have significantly increased among the patients. So Dr. Lindquist talked a little bit kind of about staffing. So, really we're running a kind of a mini COVID unit at this facility, and these patients are getting vital signs between every 4 to 6 hours or 4 to 8 hours. As you can imagine, many of them are very sick, and we're talking about one nurse or maybe two to take care of all of these patients on top of the people that are continuing to stay healthy and live there. Next slide. Other things that we are dealing with is that, again, many of our patients who live at this facility have dementia. And I'm just seeing my residents really decline from a cognitive standpoint. So, at least I'm very, very much appreciating the benefit of some of these non-pharmacologic interventions that I think geriatricians constantly harp on for our dementia patients, because without the structure of the day and the activities that these patients have gotten used to, they're really starting to decline. The staff members that they've become familiar with are no longer there because the facilities had to bring in other staff, unknown staff to help take care of the patients. Many of them are isolated. So you can imagine a patient with dementia being in a room just with 4 walls and nothing else to do. No social interaction is not good. And then, we've had to cohort patients with COVID together in a different separated section. So, they're around people that they may not necessarily be familiar with. There's been much more increased agitation at the facility. So there's more residents now on antipsychotics. And we've had a really hard time enforcing the social distancing. A lot of our patients like to wander. That's the great benefit of being in a locked dementia facility. And you can imagine that a dementia patient who likes to wander, who doesn't understand that they have COVID and that they need to stay in their room, has been a real challenge for the staff, and has also been a factor in increasing agitation in these patients. Next slide. We've also seen an increase in wounds because the residents are spending more time in bed or in a chair, and there's less staffing available. There have also been more falls and fractures. So I've had 3 patients now who have not tested positive for COVID, but have fallen and suffered fractures. And a lot of the patients are starting to decline emotionally because services we're getting, such as PTOT and speech, have had to stop. So even the patients who don't have COVID are really starting to suffer. Next slide. So kind of just to end, a little bit of positives. So, now we have PPE, which is great. Thankfully, after we had a few cases, the IDPH stepped in and really helped the facility to try and manage this. So they have adequate PPE, as do I. And now we have COVID testing, which is great too. So actually, somehow the corporate office got a hold of a COVID testing, one of the rapid COVID testing machines. So we're still trying to figure out how to use it appropriately, but we have that available. We're not really sure what to do with the results or how accurate they are yet. But thankfully, IDPH has been more involved and has been helpful in kind of helping us think through this. And we're really trying to interact more now with the neighborhood and the community, especially for the residents that are still able to wander around and are not under isolation. And so, we've set up areas with dog treats outside of the windows, so that the neighbors in the community can walk by with their dogs and allow the residents who can't go out just a little bit of time with the pets. So it's been nice. So there's been a few positives, but it's been a stressful and difficult 3 weeks. It's been very emotional for me and for all the staff members there. And so for any of you that do have family members in these facilities, thank them, because the staff there, they're just doing an incredible job. They're going above and beyond what they need to do for the residents and what they really are able to do for the residents. And so it's a work in progress, but we're getting through it.